Antimicrobial Stewardship, Improving Clinical Outcome by Optimization of Antibiotic Usage. This has actually been my passion for a couple of years now, and it's an honor to be relating with this topic at this time. During the course of this interaction, we shall be going through this topic by looking at an introduction, antibiotic resistance or antimicrobial resistance, and then we'll attempt to look at what antimicrobial stewardship is, and then we'll attempt to wrap up. So without wasting much time, I want to quickly take a look back at the introduction of antibiotics to medical practice. Now, it is true, the statement of fact that in recent greatest medical advances have been made possible by virtue of the discovery of penicillin in 1928 by Alexander Fleming. And as such, this revolutionized medical practice, as a lot of surgeries that would have been very risky are now possible. However, with this discovery came development of resistance. And resistance, simply put, occurs when microorganisms evolve such that the antimicrobials or antibiotics that used to kill them or slow their growth or activity no longer are able to do so. This fact was alluded to by the person who also discovered penicillin, Alexander Fleming, a few years later, precisely in 1945, where he stated that the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin-resistant organism. Emphasis on the phrase, penicillin-resistant organism. So he also alluded to this fact before now, that the thoughtless use or the irrational use of these miracle drugs, as it were back then, will lead to resistance and ultimately death of patients. How did resistance come about in terms of, as with regards to those of us in clinical practice? The WHO, while a couple of years back, while talking about handling antibiotics with care, alluded to 6 reasons why we have antimicrobial and antibiotic resistance today. And for us in clinical practice, some very important reasons why there's so much antibiotic resistance happen to be overprescribing of antibiotics, poor infection control in our hospitals and clinics, patients not finishing their treatment, the prescription that for antibiotics that should last 10 to 14 days, they take the first 2 days or 3 days, they are better and they are done. Antibiotics are supposed to be 8 hourly or 6 hourly, or BD, they are taking once a day, just at their own discretion, sometimes due to poor counseling on the part of healthcare providers. And then there is a lack of hygiene and poor sanitation, and lack of new antibiotics development. The importance of antimicrobial or antibiotic resistance to us as clinicians. Very importantly, where there is resistance, there is treatment failure and additional side effects. Where there is treatment failure, the patient stays longer in the hospital with the attendant psychological disorders due to reduction in quality of life. And this also adds to economic and psychosocial burden on the family, with a greater likelihood of death occurring. And this also leads to broader spectrum antibiotics being used empirically. Now, I would not want to be dwelling on the definition of the antimicrobial stewardship that has been touched, and the various rights have also been touched. However, it is important to stress that in order to achieve all of these rights, the antimicrobial or antibiotic stewardship team is inevitable. This has also been shown what the stewardship team should comprise of. So I will not also be dwelling on that at this point. However, what is the benefit, the ultimate benefit of antibiotic stewardship? In our various facilities where there is antibiotic stewardship, there will be decreased antibiotic resistance or antimicrobial resistance. There will be reduction in cost of care. And ultimately, there will be increase in good patient outcome. Now, what is our role as pharmacists in ensuring appropriate use of antibiotics? And the responsibility, I'll be looking at the responsibility of pharmacists in 3 areas: optimal use of antimicrobial agents, reducing transmission of infection, and thirdly, educating health professionals, patients, and the public. So let's quickly take a look at how we can optimize antimicrobial use in our various facilities. Now, in promoting optimal use of antimicrobial agents, it is important that through the Drugs and Therapeutic or Pharmacy and Therapeutics Committee, we develop policies that support optimal antibiotic use. And what will these policies include? Such policies must include automatic changes from IV to PO in antibiotic or antimicrobial therapies. What this means is that we should not have a system where prescription for antibiotics, IV antibiotics, are open. And or IV antibiotics should be for specific period of time. There's a statement that says whenever the GI works, use it. So we want to limit the use of IV antibiotics, as the IV routes, as we are all aware, increases the chances of further infections. So such policies should contain protocols for timelines for switching from IV to oral. And then such policies should also contain dose optimization, which would include dosage adjustment based on therapeutic drug monitoring, optimizing therapy from highly drug-resistant bacteria. We should have automatic alerts in situations where therapy might be unnecessarily duplicated, where prescription for antibiotics of similar spectrum of activities are combined, trying to use combination therapy. And then such protocols, such policies should also contain dose adjustment in cases of organ dysfunction. And there are documented adjustments, like we are familiar with gentamicin, where we do not have facility for therapeutic drug monitoring. There are documented adjustments for antibiotics in reference book, and a very good book that can come in, reference material that can come in handy, is the Drug Information Handbook from the American System Pharmacists Association or something like that. It's a very, very good book that you can use. Now, if you look at gentamicin, for instance, for a 70 kg patient with a renal creatinine clearance of 41 to 50 mils per minute, without much stress, you can see that you should not exceed 360 milligram in 48 hours for such a patient. So where we see a prescription that is having 80 milligram gentamicin 8 hourly, that tells you there's going to be a problem for a patient with a creatinine clearance of 41 to 50. So it's not a one dose fit all. For such a patient, if you do an 80 milligram gentamicin 8 hourly, that will be giving you about 400 and something milligrams in 48 hours. So reference materials helps out in dosage adjustment. Now, such protocols should also contain time-sensitive automatic stop orders for specific antibiotics prescription. It should also contain measures for detection and prevention of antibiotic-related drug-drug interaction. And very importantly, it should, together with the microbiology laboratory personnel, an antibiogram should be designed. Now, I'll be stressing so much on antibiogram, even though the first speaker made mention of it. I am a strong advocate for antibiogram, especially because of empiric therapy and antibiotic recycling, which was also mentioned. I'll just quickly use this as an example. Now, usually an antibiogram is a compilation of the culture and sensitivity over a 1-year period in a facility. Now, what does this antibiogram help us to do? If you take a look at this antibiogram, you can see that it covers the period of January to December 2016 for this health facility. Now, on the first column, you see the isolates, and then you see from where these organisms were isolated, urine. And on the first row, you see the antibiotics that the organisms were challenged with. Now, from this, take for instance, E. coli. If you take a look at E. coli for 2016 for this facility, you take note that amikacin and meropenem had a 99% sensitivity for that year. What does this mean? In drawing up in determining the medication for empiric therapy before the culture and sensitivity result comes out, the antibiogram gives you a guide of which medication. Because if you look at this antibiogram, for instance, along the chain of organisms, you will see that amikacin and meropenem have the greatest sensitivity. However, through the Drugs and Therapeutic Committee, we can use the antibiogram to design which medication should be used for empiric therapy, rather than the one drug fits all system we have, where ceftriaxone seems to be the all and all. From the Drugs and Therapeutic Committee, other criteria can be looked into. Are we for empiric therapy, should we consider medications that have 70 or 80% sensitivity and above? Then you also want to look at cost. You also want to look at comorbidities. You also want to look at the sex of the patient vis-a-vis pregnancy and all of that. So there are other factors that will come in, but the antibiogram helps us to select the antibiotics to be used for empiric therapy for the following year. Now, take for instance, in 2016, we say amikacin and meropenem should be our medications for empiric therapy. Yes, in 2017, we'll take a look. In 2018, we'll now look at the culture and sensitivity for 2018 again. Now, if you now take note that in 2017, amikacin and meropenem sensitivity, instead of 99%, is now showing 70%. And augmentin, which is 44% in 2016, has now risen to, say, 80 or 90%. What this now helps us do in 2019 is to keep amikacin or rest amikacin and meropenem, while we now move on to augmentin that we're not using. And then if in 2020, we look at the antibiogram again and we see that the sensitivity for augmentin is now dropping, and that for amikacin and meropenem is increasing, we can now recycle by bringing back that which was not very sensitive but is now very sensitive, bringing it back to use. So that is the beauty about an antibiogram. So it helps us determine which drugs to use for as empiric therapy and which drugs to rest or recycle. Now, there is another key use of this antibiogram, as we will soon see shortly. So from the antibiogram, as clinicians, we must handle antimicrobials and antibiotics smartly. What this simply means is that when starting off an antibiotics, you need to choose an appropriate empiric regimen, which should be based on the antibiogram. Now, having chosen the appropriate empiric therapy, in terms of maintenance of therapy, what should you do? We say target, de-escalate, and discontinue therapy. What de-escalation simply means is you started with a broad spectrum antibiotics, which you picked out as a result of your analysis of your antibiogram. Haven't gotten the culture and sensitivity results, you then de-escalate to the specific antibiotics that is sensitive to that organism. So that way you protect the integrity of the broad spectrum antibiotics and you make use of the specific antibiotics. So like it is always stated, always make culture and sensitivity result is the key to treating infections. Now, I haven't seen what maintenance of therapy should be like. What about the A? Before selecting the antibiotics, you want to ask yourself as a clinician, are you treating an infection or a colonization? Now, if you are treating a colonization, you don't want to eradicate all the the natural flora. So your target will be more of a bacteriostatic rather than a bactericidal organism, antimicrobial. And then the arrow is simply for the routes. Like I said, as much as possible, if the GI is functional, make use of the oral route. However, if the patient condition, another predisposing factor, negates against use of oral antibiotics or antimicrobial, you do IV. But as soon as it is possible and convenient to switch to an oral, that switch must be done. And we say all antibiotics or antimicrobial must be time-bound. You should not have open prescriptions for antimicrobials. So that is a smart use.
Dr. Ejiro.
Yes.
Yes, you have 7 more minutes.
Okay, thank you very much. So other things the pharmacist can do as member of the stewardship team is reducing the transmission of infection by participating in infection prevention and control committees, encouraging the use of single-dose packages of sterile products rather than multiple dosage containers, encouraging routine immunization, and striving for zero tolerance of healthcare associated infection through use of hand sanitizers and gloves. Now, in the DEL suite, these are some of the settings. Before entering the ward, you use the hand sanitizers to reduce infection in the system. Now, the educational activities of the pharmacist will include things like this: health professionals, talking to health professionals on use of antimicrobial and antimicrobial resistance, proper counseling of patients and clients. All of these and conferences and seminars like this one we are having now are all educational activities the pharmacists can engage in. So what have been said so far? Antimicrobial stewardship practice ensures appropriate and judicious prescribing, dispensing, and administering of antimicrobials. And pharmacy leadership and healthcare professionals should support clear governance arrangement to facilitate leadership, engagement, and accountability for actions to combat antimicrobial resistance through rational and sensible use of antimicrobials. Now, emphasis on rational and sensible. For some of us who, on a more general note, yes, we use misuse and abuse interchangeably, but for some of us who have interest in substance abuse, we're a little bit more reserved in use of the word abuse. That is more for substances that affect mood. So we have substances of abuse, and antimicrobials are not one of those substances. So that's why I'm a little bit more careful in my choice of the use of rational and sensible use. In conclusion, as pharmacists, we are the most competent in all aspects of antimicrobial use in patient care, as we possess scientific knowledge for the entire medication use process. And therefore, it's our responsibility to take prominent roles in minimizing antimicrobial resistance by ensuring that our procurement, preparation, storage, security, distribution, dispensing, administration, and safe disposal of antimicrobials support adherence, minimize interactions, and ensure quality and efficacy of our antimicrobials. And like Dorothy Baker says, without significant intervention, we are coming to the end of the days where 10 different antibiotics can be utilized to treat serious E. coli infection. If we do not make it our problem now, it will certainly be our problem later when we are asked what antibiotics to use for a pan-resistant E. coli infection, and the answer will be nothing. So therefore, it is important that as healthcare professionals, we need to protect the integrity of our antimicrobials for our future generation. Thank you very much.